Okay, let's unpack this. Think about someone in the hospital, maybe the ICU. They're relying on a machine for, well, the most basic thing, breathing.
Right, a mechanical ventilator. It's literally pushing air for them because they can't manage on their own. It's obviously life-saving tech.
Absolutely.
Yeah.
But just as critical, and maybe less obvious, is getting them off that machine, letting them breathe freely again.
That's the core of it. Clinicians often call it weaning or sometimes liberation from the ventilator. And it's definitely not flipping a switch. It's a real process.
And that process is what we're diving into today. We've got a clinical handout here that kind of lays out the roadmap, the checks, the methods they use.
Yeah, it's quite detailed.
So our mission for you listening is to go through this step by step, pull out the key signs, the techniques, and importantly, some really crucial distinctions this document makes. So you really get what's involved.
It starts, interestingly, well, before they even try to reduce support, there's a whole pre-weaning phase.
Right, phase 1, pre-weaning. Assessing readiness. The handout makes it clear you have to answer some big questions first, like, are they even ready to start trying?
Exactly. It's like a checklist. First big one. Is the original reason they needed the ventilator getting better? Or, ideally, is it resolved?
Makes sense. You can't really remove the support if the underlying fire is still burning, so to speak.
Precisely. If the pneumonia is clearing up or they're recovering well from surgery, then you look at the breathing mechanics, and the source gets really specific on oxygenation.
Yeah, it's not just are they getting oxygen. It's about how much support they need for adequate oxygen. There are numbers.
Definitely numbers. They're looking for things like PO2 over 60 mmHg, FiO2, that's the oxygen percentage, ideally less than 40 or 50%. PEEP, that positive and expiratory pressure below 10.
Okay.
And a PF ratio over 200. Plus, their pH needs to be reasonably stable, like at least 7.30. These targets basically say the lungs are doing a decent job with less help.
So the lungs are capable, and they're not needing extreme settings.
Yeah.
But it's not just the lungs, right? The handout stresses overall stability, too.
Absolutely. Medical and hemodynamic stability. So beyond breathing, are there acid-base issues sorted? Metabolic stuff? Kidneys? Electrolytes?
And the heart. Cardiovascular system.
Yeah. Is blood pressure stable? Are they needing tons of drugs to keep it up? Because trying to wean someone unstable elsewhere is, well, risky. It sets them up to fail.
Okay, and the final check in this initial phase.
The most basic one, really. Can they actually try to breathe on their own? Are those respiratory muscles even kicking in?
Got it. So, clinical picture, vital signs, labs. But the handout mentions more for pre-weaning. Specific measurements, indices, the numbers that matter.
Right, these are more objective scores trying to predict success. Quantifying things a bit more. One of the older ones mentioned is the CR-OT score.
CRP. What does that stand for again?
It bundles a few things. C is for compliance, how stretchy the lungs are. R is rate, breathing rate. O is oxygenation, using that PO2-PaO2 ratio. And P is MIP, maximum inspiratory pressure. Muscle strength, essentially.
Okay, that's a lot rolled into one. Is there a formula?
Yeah, it's sit-in times MIP times PO2-PaO2 divided by F, the rate. But the key takeaway from the source isn't memorizing the formula, it's the threshold. A score over 13 millihole per breath per minute suggests a better chance of success.
So it combines the quality of the breath, like compliance and strength, with the outcome, like oxygenation and rate.
Kind of, yeah. Trying to get a fuller picture. Another index mentioned is airway occlusion pressure, P0.1.
P.1, how's that measured? Sounds quick.
It is. The source says it's measured just 100 milliseconds after they briefly block the airway, right when a breath starts.
And what does that tell you?
It's interesting. It seems to correlate with the patient's central respiratory drive, sort of how hard their brain is telling them to breathe right at that instant.
Okay. And what's a normal P0.1 value?
Up to about 6 centimetal H2O is considered normal. But if it's higher than 6, the handout warns that weaning might be more difficult.
A high number suggests maybe too much drive, like they're struggling.
Could be, yeah. Maybe a sign of distress or impending fatigue. Then there's the one most people have probably heard of, the RSBI, Rapid Shallow Breathing Index.
Ah, F over VT. Heard that one.
Yeah, FVT. It's pretty intuitive. Just the spontaneous breathing rate. F divided by the size of their spontaneous breath, the tidal volume VT, but measured in liters.
So quick breaths divided by small volume.
Exactly. The idea is that efficient breathing is slower and deeper. Rapid and shallow is tiring. The magic number from the source is 105. You want to be below that.
Below 105 is good, means slower, deeper breaths.
Generally, yes. More efficient pattern. If the RSBI is over 105, the source says the chance of successful weaning goes down. It points towards that rapid, shallow pattern that's hard to keep up.
Okay. Clinical checks done. Oxygenation good. Stability confirmed. Looked at CRP, P21, RSBI. If things look promising, then you actually start trying to reduce the machine's help. Phase 2.
Exactly. The weaning phase.
Yeah.
The core idea, as the document outlines it, is giving the patient chances to breathe on their own, these spontaneous breathing trials, or SBTs maybe alternating with rest periods back on the ventilator.
And the source talks about different ways to do this.
Yeah, a couple of main approaches. First, those SBTs. The handout says you can do them right on the ventilator itself, or using something simpler called a T-piece.
A T-piece that just hooks up to oxygen, right? Bypasses the vent's main functions.
Pretty much. Doing it on the vent lets you monitor pressures and volumes more closely, though. The source flags patients who might wean quickly if they pass an SBT.
Who are they?
People whose original problem resolved fast, like within 72 hours, who have good weaning numbers, those indices we discuss, and who look good during an SBT that lasts, say, 30 minutes to maybe 2 hours.
Okay. And the vent settings for an SBT, what does the handout say?
Typically, the source states 0 pressure support, 0 PS, and 0 CPAP. But it adds a really important note. Many places do use a little bit of CPAP, often around 5 centimole H2O.
Why add CPAP if it's supposed to be spontaneous?
Good question. It's not really to support their breathing muscles. It's more to overcome the extra resistance caused by the breathing tube itself. Makes it feel less like breathing through a narrow straw.
Ah, okay. That makes sense. So if a patient nails all that good parameters, passes the SBT.
The source suggests most of those patients can then come off the ventilator. And it's a crucial if mentioned here. They can also protect their own airway. Then the tube can potentially come out.
We definitely need to circle back to that airway protection. So SBT is one way. What about SIMV?
Yeah.
Synchronized intermittent mandatory ventilation.
SIMV is a mode where the machine gives a set number of guaranteed breaths, but the patient can breathe spontaneously between them. Weaning with SIMV usually involves slowly turning down the machine's rate.
How slowly?
Based on how the patient's doing their blood gases. The handout mentions typically reducing by maybe 2 breaths per minute at a time, letting the patient take over more and more.
Sounds logical.
Yeah.
But does it always work smoothly?
Not always. The source points out a common issue. SIMV weaning often kind of stalls when the machine rate gets really low, maybe 2 or 4 breaths a minute.
Stalls, why?
The handout suggests it's often due to muscle fatigue and maybe developing some respiratory acidosis. Even with just a few backup breaths from the machine, the effort of pulling all their own breaths through that artificial tube can still be too much. They tire out.
So paradoxically, very low SIMV might actually be harder work than a well-managed SBT sometimes because of the tube resistance.
It can be, yeah, that continuous work of breathing. The source does note SIMV is often considered for, say, COPD patients or folks on the vent longer term. Maybe the idea is the guaranteed breaths provide necessary rest periods for them.
And you can add pressure support to SIMV plus PSV.
Yes, that's another approach mentioned. You combine the gradual rate reduction of SIMV, but you also add a low level of pressure support just for the patient's spontaneous breaths.
How do you know how much PSV to add?
The source gives a couple of ways to judge. You could increase PSV until their own breaths get to a decent size, like 5 to 8 millil per kilogram of ideal body weight. Or you raise the PSV until their spontaneous breathing rate naturally slows down to something comfortable, like under 20 breaths per minute.
So the PSV helps make their own breaths bigger and easier, less frequent between the machine's breaths.
Exactly. It offsets some of that work of breathing through the tube for their spontaneous efforts. And like SIMV alone, the source says this combo is also often used for COPD or long-term ventilation patients.
Okay. The handout also mentions NPPV, non-invasive positive pressure ventilation. That's with a mask, right? Not a tube.
Correct. Mask or nasal prongs. It seems its role, based on this handout, is more supportive around the weaning process rather than a primary method for getting off the invasive tube itself.
Supportive how?
Well, the document lists a few specific uses. It could be a bridge for COPD patients who fail an SBT. Instead of staying intubated, they might switch to mask ventilation.
Okay, transition tool. What else?
It's also used sometimes for patients who pass their SBT but are still seen as high risk for failing after the tube comes out. Maybe they're weak or have other issues. NPPV gives them some extra support non-invasively.
And a final rule.
Yeah, helping patients who develop low oxygen levels, hypoxemia after extubation. Putting them on NPPV might prevent them from needing to be reintubated.
The source also just lists monitoring during weaning as part of this phase?
It does. Clearly vital, you have to watch the patient closely, though the handout doesn't spell out exactly what parameters get monitored during the weaning trial itself, just that it's essential.
Right, which leads us to the end goal, really, extubation.
Removing the tube. The source defines the end of weaning as when the patient can handle their own breathing adequately, spontaneously, without machine help. But then it makes this incredibly important point.
This feels like the big takeaway from this document.
I think it is. It explicitly says, weaning and extubation should be separate decisions. And here's the kicker. Those weaning parameters we talked about, CROP, P.1, RSBI, even passing an SBT, they tell the clinician nothing about whether the patient can maintain and protect their own natural airway once that tube is gone.
Wow. Okay, so you can prove your lungs work,
Yeah.
that you can move airway on your own, but that doesn't mean you can, say, cough effectively or swallow safely or keep your airway from getting blocked.
Exactly that. The source really drives home that they're different skills, breathing mechanics versus airway protection and patency. You need both to succeed off the ventilator.
Okay, let's take a breath ourselves and just quickly recap the journey this handout maps out.
Probably a good idea. A nice, slow, deep one.
Hopefully. So we started with that crucial pre-weaning check. Is the original problem better? Are the physiological markers okay?
Right. Then looking at those objective numbers, CROP, P01, RSBI, trying to predict readiness based more on mechanics and drive.
And if that looks positive, you move into actually trying to wean. Methods like spontaneous breathing trials, maybe on the vent or a T-piece.
Or using SIMV, gradually reducing the rate, potentially adding pressure support to help the patient's own breaths, and remembering NPPV's supportive roles around extubation.
And we landed on that really critical distinction the source makes. Passing the breathing tests, the weaning part, isn't the same as being ready for extubation.
Yeah, getting the tube out involves more than just lung function. It's about airway safety, too. Really highlights the complexity clinicians are juggling.
It really does. Which leaves a question for you, thinking about everything we've just drawn from the source. If those standard breathing tests don't predict airway protection, what other abilities or assessments do you think might be crucial before that tube can finally safely come out? Something to chew on, based on the layers this handout uncovered.